start?
Start చేసి వస్తాను చూద్దాం.
వస్తుందా? ఓకే. Today's class is respiratory failure. It's a very important question. Respiratory failure means when pulmonary gas exchange fails to maintain normal arterial oxygen and carbon dioxide levels in the blood. That is respiratory failure. The type 1 respiratory failure usually occurs due to hypoxia, when the partial pressure of oxygen is less than 60 millimeters of mercury, or when a normal or low partial pressure of carbon dioxide less than 50 millimeters of mercury. When the oxygen level is less than 60 millimeters of mercury, when carbon dioxide level is less than 50 millimeters of mercury, that is usually seen in a type 1 respiratory failure. The hydrogen ion in acute renal respiratory failure normal or increased. In chronic respiratory failure, hydrogen ions may be sometimes normal, and because they may be washed out by the renal tubules as a compensatory mechanism. Then you have bicarbonate, which is normal in acute and chronic respiratory failure. The causes of respiratory failure are acute asthma, pulmonary edema, pneumonia, and lobar collapse, and pneumothorax, pulmonary embolism, and ARDS, that is acute respiratory distress syndrome. The chronic respiratory failure is common in emphysema, lung fibrosis, lymphangitis, carcinomatosis, right to left shunt, and brainstem lesions. Type 2 respiratory failure is seen in hypoxia, less than 60 millimeters of mercury in the blood. That is the oxygen tension in the blood. Partial pressure of carbon dioxide less than 50 millimeters of mercury. Acute, you see the hydrogen ions which are increases. Bicarbonate may be normal in both acute and chronic, and usually seen in a severe asthma and acute exacerbation of COPD. Neuropathies like paralysis, neuromuscular junction, Guillain-Barré syndrome, neuromuscular dystrophies, muscular dystrophies, especially limb girdle type, narcotic drugs, hypoventilation, and flailed chest due to chest trauma. The chronic is Causes are mostly COPD. Hydrogen ion is increased in COPD, and they have kyphoscoliosis, sleep apnea, and myopathies, ankylosing spondylitis, kyphoscoliosis. All these will cause chronic respiratory failure. The management is a prompt diagnosis and management of the underlying cause, and treatment will reverse the precipitating event. Tracheostomy, laryngeal obstruction, fixation of the ribs, inflated and inflamed chest injury, and reversal of narcotic poisons, bronchodilators in acute severe asthma, ICD in a tension pneumothorax will restore good gas exchange in these individuals. In laryngeal obstruction, interfering with breathing, you do laryngeal tracheostomy and improve the ventilation and the fixation of ribs. In chest injuries, rib fractures, and in patients who are under narcotic poisons, who develop hypoventilation, respiratory failure, usually by fixing the ribs, the oxygenation will improve. In asthma, giving bronchodilators in the form of nebulization can improve asthma. The ICD in tension pneumothorax, the moment you put a needle or a tube in intercostal drainage tube, this will restore the gas exchange in these individuals. So, in acute LVF, pulmonary embolism, myocardial infarction, opiates are important in chest pain. Opiates never be used in asthma or COPD except immediately prior to the during assisted ventilation, mechanical ventilation. When you are planning for assisted mechanical ventilation, then only you can give opiates or asthma and COPD. One should never give opiates on any other sedatives, better to avoid. The aim to restore adequate oxygen levels and and oxygen therapy with or without mechanically assisted ventilation is important. So, untreated severe hypoxemia include systemic hypotension and pulmonary hypotension, leads to cerebral dysfunction, confusion, and coma. Then how to treat a patient of respiratory failure? The delivery of oxygen to tissue mitochondria depends on several factors, including inspired oxygen concentration, alveolar ventilation, ventilation-perfusion, distribution within the lungs. So the moment respiratory failure, you make a diagnosis, you start giving oxygen. The oxygen delivery of oxygen to tissue mitochondria depends on several factors, including inspired oxygen concentration, alveolar ventilation, ventilation-perfusion, distribution within the lungs. These are all the factors responsible for the oxygenation of our species. Then you have hemoglobin and concentration of agents such as carbon monoxide, which may bind to hemoglobin, influences on oxygen, hemoglobin, dissociation curve, and cardiac output and distribution of capillary blood flow within the tissues. Then the oxygen therapy usually improves hypoxia by increasing alveolar partial pressure of oxygen in poorly ventilated lung units. However, in conditions where dissaturated blood is completely bypassing aerated lungs, example right to left shunt, or completely consolidated lobes, increasing forced inspiratory oxygen has little or no effect on arterial partial pressure of carbon dioxide when there is a shunt, that is a right to left shunt, is present in the heart or in the lungs or elsewhere. So careful measurement of arterial partial pressure of carbon dioxide when breathing 100% oxygen allows calculation of the percentage of cardiac output following through the shunt. The careful measurement of arterial partial pressure of oxygen when breathing 100% oxygen allows calculation of the percentage of the cardiac output following through the shunt. High flow oxygen 35 to 60% is appropriate treatment in respiratory failure. Example, acute severe asthma, pulmonary edema, pneumonia because of respiratory drive is high, and COPD patients with type 2 respiratory failure develop abnormal tolerance of raised carbon dioxide levels in the blood, which depends on hypoxic drive to breathe. In these patients, lower concentration of oxygen, that is 24 to 28%, may be needed to avoid precipitating worsening respiratory depression. The toxic effects of oxygen. When you are giving oxygen, 100% oxygen is toxic if inhaled for more than few hours, and premature infants develop retrolental fibroplasia and blindness in premature infants. In adults, pulmonary oxygen toxicity resulted in a pulmonary edema and free radical damage, leading ultimately to fibrosis. High concentrations, 40 to 60% of oxygen via high flow mask are useful in type 1 respiratory failure, pneumonia, asthma, pulmonary edema. When high flow masks are used for a long period, oxygen should be humidified by passing it over warm water. High flow masks are used for a long period. Oxygen should be humidified by passing it over warm water. Then low concentration is 24 to 28%, the most accurate method for delivering a type 2 respiratory failure. Once patients are stable, 1 to 2 liters per minute delivered via nasal cannula allows patients to eat and to undergo physiotherapy while continuing to take oxygen. That's once they are improving from respiratory failure, they can be given 1 to 2 liters per minute oxygen via nasal cannula, allows patients to eat and undergo physiotherapy while continuing to take oxygen. So the humidification not required with low flow masks or nasal cannulae. High proportion of oxygen mixed with oxygen in chronic oxygen delivery from cylinders delivered to home or more conveniently from oxygen concentrator is given via low concentration masks and nasal cannulae for indications. Portable oxygen increases the exercise tolerance and is helpful to benefit from outdoor activities in those individuals who can go to shopping or go for a walk. The monitoring of response to therapy. The arterial blood gases taken at presentation or at admission repeated within 20 minutes to know the treatment has achieved partial pressure of oxygen levels in the blood or not. That one should be monitored. Then the arterial blood gases should be done after starting treatment within 20 minutes. So then to know whether the oxygen levels and the carbon dioxide levels in the blood are coming to normal or not. If hypoxia persists despite appropriate oxygen therapy and progressive hypercapnia is developing, as carbon dioxide levels are maintained at 50 millimeters of mercury with acute respiratory acidosis develops, and that also should be monitored in those individuals. And patient becomes exhausted, needs ventilation support temporarily by non-invasive ventilation, non-invasive ventilation support, or by intubation or by mechanical ventilation. Very ill patient should be considered. Then chronic and acute and chronic type 2 respiratory failure, especially in COPD, carbon dioxide retention may occur on chronic basis, and the patient may develop acidemia and corrected by renal retention of um, bicarbonate, which results in the plasma pH remaining within normal range. The compensation pattern seen in neuromuscular disorders and kyphoscoliosis is maintained until there is further pulmonary inset. Example, COPD precipitates acute and chronic respiratory failure. The further acute increase in the partial pressure of carbon dioxide results in acidemia and worsening hypercapnia, leads to drowsiness and confusion and coma. The aim of treatment in acute or chronic renal respiratory failure to achieve safe partial pressure of oxygen more than 7.0 kPa or 52 millimeters of mercury without increasing the partial pressure of carbon dioxide and acidosis, while identifying and treating the precipitating condition. So these patients usually have pre-existing lung disease and only small insult is required to tip the balance towards the respiratory failure. COPD patients may not feel distressed despite being critically ill with severe hypoxemia, hypercapnia, acidemia. And then we must evaluate the patient's level of consciousness, ability to cough effectively, and look for respiratory drive. It gives a clue to indicate whether the patient will be able to tolerate non-invasive ventilation, whether physiotherapy will be of some help to retain retained secretions to come out. 24 to 28% oxygen with careful monitoring of blood gases is required, and physiotherapy, bronchodilatation, broad spectrum antibiotics and diuretics. The risks of worsening hypercapnia and coma must be balanced against those of severe hypoxemia, which may cause fatal arrhythmias or severe cerebral complications like convulsions. Slight increase in partial pressure of oxygen have a greatly beneficial effect on tissue delivery. Tissue oxygen delivery. Since the partial pressure of oxygen values of these patients are often on the steep part of oxygen saturation curve, the physical signs of carbon dioxide retention are confusion, flapping tremor, bounding pulse controlled by oxygen therapy, increased partial pressure of oxygen associated with reduction in pH. The non-invasive and invasive ventilator support may be required in such patients. Intubation required for remediable cause to give good quality life to the patient. You have doxaprom is a respiratory stimulant 1.5 to 4 milligram per minute by slow IV infusion should be used as respiratory stimulant, and where non-invasive ventilation not available or poorly tolerated or in those with reduced respiratory tract, it provides a minor or a transient improvement in arterial blood gas parameters. The mechanical assisted ventilation. Severe respiratory failure type 1 and 2 who failed to improve with optimal medical therapy may require mechanical ventilation by face mask, nasal mask, or invasive via an endotracheal tube. Intubation. Intermittent positive pressure ventilation with full sedation is appropriate. So, non-invasive ventilation of great value in a long-term treatment in skeletal deformities, myopathies, central alveolar hypoventilation, and it is also effective in acute on chronic respiratory failure due to exacerbation of COPD, where it reduces the need for intubation and shortens hospital stay. And it's used to wean such patients from intermittent positive pressure invasive positive pressure ventilation. Then you have the lung transplantation where it should be done. Parenchymal lung disease, bilateral parenchymal lung disease, cystic fibrosis, emphysema, pulmonary fibrosis, Langerhans cell histiocytosis, and lymphangioliomyomatosis, and obliterative bronchitis, pulmonary vascular disease, like pulmonary hypertension, and thromboembolic pulmonary hypertension, renal-occlusive disease, and Eisenmenger syndrome. These are all the causes where you can plan for lung transplantation. Single lung transplantation in older patients with emphysema, with single lung transplantation in older patients with emphysema, with intrapulmonary restrictive disorders such as lung fibrosis, etc. The contraindications for lung transplantation: chronic bilateral pulmonary infection, cystic fibrosis, bilateral bronchiectasis, combined heart and lung transplantation, Patients with chronic bilateral pulmonary infection, cystic fibrosis, bilateral bronchiectasis, combined heart and lung transplantation remains necessary for patients with advanced congenital heart disease such as Eisenmenger syndrome and primary pulmonary hypertension. Unresponsive to prostanoid therapy and living lobe transplantation has been introduced. So this is how the respiratory